I'm going to talk to you about a program that we've developed to be able to talk about assessment and what's at stake with assessments, in particular in the clinical setting, because it's particularly in the clinical setting and it's when we intervene with young people and families that we don't know exactly how to start with the assessment. So I'm going to talk about an experience that we had in our team, and it started with a purely clinical point of view, and then we realized that we had to start assessing things, and it's not an easy task to accomplish. And I'm going to talk about all of our difficulties that we encountered with our assessments and share our experiences. I think it's the first time that, rather talking about positive results and putting this forward, I'm going to actually concentrate on what was tough, what was difficult about this. First of all, with the KEEP program, how did this evolve? Well, to explain the clinical interest in all of this, I believe that people in the who are here in the room know that I started by working on ADHD, attention deficit with a hyperactivity disorder. And we knew that ADHD, in particular in a specialized setting, it does not often present alone. Often there's comorbidities. And there's the whole large spectrum of externalized disorders and behavioral disorders. And I'm talking about behavioral disorders. It's not always other disorders, and sometimes these are the most problematic because we don't actually meet the criteria of reaching a diagnosis. But it's important to see what are the dysfunctions for the child and the school and for their socialization, in particular for their parents. So that was the basis for all this. And I tried to look at what's being done in the scientific literature. We know in terms of behaviour disorders, the earlier we can act, the more effective it will be. I believe that all of the other speakers who have preceded me have pointed this out. And to look at one of the main studies then, which is one of the most solid, we've got the PATS Preschool ADHD treatment study. That's the equivalent for those of you who know the MTA study, which deals with children of school age, compare medication compared to behavioural interventions. It's the equivalent of this study for preschoolers. You will also know that before the age of 6 years of age, normally our medication that's available to us it would not actually be legal because we are not meant to prescribe psychostimulants before the age of 6. So the guidelines recommend to us that we should start with other types of interventions, in particular parental interventions, before we move on to medication. So that's what happened with this study. First of all, they treated children with behavioural interventions, and those who didn't respond to those interventions then went on to take medication. And the intervention that was used in this study was the COPE program, which is the Community Parent Education Program that was developed in Canada, in Ontario, by Dr. Jack Cunningham from the University of McMaster University. This is a program which has been scientifically validated, as has been explained by Patricia, because scientific rigor is important. If we're talking about evidence-based studies, then there needs to be controlled randomized trials that prove the effectiveness of this study. And this study meets these criteria in terms of good, solid scientific evidence. We were also interested in this program because it was also used in the US in this perspective of services before generalization. We know the problems with the waiting lists in Quebec, and getting access to services is a problem not just in Quebec. We find this problem throughout Canada, basically. If we're talking about behaviour disorders, we estimate, according to studies, that around 2/3 of children do not have access to the mental health services needed. And here I'm talking about all of the different types of mental health disorders that exist. So it's difficult for them to get access to something that can be done even before the diagnosis is established, to something that would be very useful. It's also a program that has already been translated and adapted to lots of different settings. It's used a great deal in Scandinavian countries, and also there's a Spanish and English version in the US, and so on and so forth. but we didn't have any French version available. There was one version that was produced by Dr. Cunningham's team, but it was never used. And when we looked at it, it was very disappointing. So that's why we decided to develop our own French version of COPE. And we said, when we're starting to use a new program, we have to prove that it's actually relevant. Why are we choosing this program and why are we using it in this context and how can we implement this? So the general aim here was to test how we could implement this program, or what would be the best approach so that this program could fit into our care context, because it was very much used in Ontario in the community centres, whereas here we know that access to interventions goes through the CLSCs, so the equivalent of the community centre in other regions would match up with what we do in the CLSC here in Quebec. And it's a rather different model in terms of the services provided compared to other parts of Canada. So that's why we wanted to try and see how this could fit in for us. In parallel with that, we very much wanted to see the impact that this would have on waiting lists for services. And I'll announce right away that we were very disappointed because it wasn't possible to assess that particular element. If we have time, I can come back to that during the discussion part, but I'm not going to go into that in detail just now. Because when we set up this type of program, we wanted to see what the impact would be on the children that we're meeting with and their parents, because they're the ones who receive this intervention. I'm going to quickly go through the program because I've already presented it within the context of other social pediatrics meetings. And if it's not clear, then during the question period, I'll be happy to answer any questions that you may have. So it's a parental skills training program. When we're talking about training, we're talking about repetition. And it has one specific characteristic, namely they use big groups of parents, up to 25 parents. In our practices, we sometimes had groups of 30 parents at once. The group effect for Patricia said it's something that's very present amongst parents as well, this group effect or herd effect. So in terms of the effectiveness, the group effect is well proven, and also in terms of cost effectiveness, that's a very significant element. I won't go into that in detail either, but there was a study carried out to look at the cost and the effectiveness of this program in Ontario, and it was shown that there's a gain of $1,000 per child if we take 2 children when they're being in individual follow-up rather than in a group follow-up setting. So that's an enormous difference when we're talking about a disorder that occurs on a frequent basis, or a very frequent basis. And then there's a non-didactical approach. It's an active learning approach. And I think that links up with what was presented earlier, when it's the young people who have to make efforts themselves. We're going to test this out together. I hope it's going to work. Here it's the parents who have to do most of the work, compared to what we normally do in our healthcare system, where it's the practitioner who's the expert and who tries to find a recipe, so to speak, together with the parents. Whereas in this particular model, it's the parent who has to come up with their own recipe and apply it on a daily basis. So there's different subjects here. There's 10 meetings. There's a first information introductory meeting and a final meeting to conclude on all of this. And then there's 8 subjects that deal with interactions between the parents and the children. I'm going to show a small scene to you. That's how this happens in the groups, and then I'll put a question to you after you've looked at this. You want to come and play with me? Yes, of course. What have we got there? Oh, pink. Let's look at what we're doing here. If we take this pencil, we can colour in the coat black. So you need to take a black pencil. No, don't colour it in like that. Jessica, try and have straight lines. And then do some circles. That's the way. That's it. No, big girl like you, you're not meant to go over the lines. Try and stay in between the lines. No, you're going to colour in the man's pants blue. No. No, over there. Look, I'll show you how to do it. It's just over there. I colour that in blue, just like that. Papa will show you how to do it. That's how you're meant to do it. Well, I think I'll just do it for you. Just like that. I don't want to colour in anymore. Oh, okay then. Oh, it's not too bad. Well, it's a bit of a caricature there. And when we have the parental group, we ask them some questions. They laugh about this and they recognize themselves in certain forms of behavior. And they also recognize what's abnormal or the so-called errors. So we ask them to spot the mistakes. In principle, we don't give them any answers, but here I'm going to give you some possible choices of answers. That's excellent. I think that we can see what's really standing out here. Namely, what's problematic in this interaction is the fact that he doesn't pay attention to the positive behavior of his child, and he's excessively critical, and he gives excessive orders to his child. These are the three main errors that we're wanting the parents to spot, and they find these mistakes. That's the beauty of the group. They manage to come up with these mistakes, and from one group to another, we're never disappointed. We see that parents have this capacity to be self-critical. And then, now that we've recognized what was difficult and problematic with this interaction, what type of behavior would be a winning strategy, a positive strategy to correct these mistakes? And so now I'm going to put the second question to you. Once we've recognized or found the three mistakes, the next question is, what do you think would be the winning strategies to use in this situation? And there's a choice of answers here as well. So it's limiting the orders and the instructions and the control. And then number 2, continue to show the child how to draw well or colour in well. And then 3, avoid critical comments. 4, congratulate the child. And it's much more interactive when the parents are talking about all of this. And you can believe me that parents do find these positive strategies, avoid being critical and reinforcing things and limiting their orders and reinforcing positive behavior. They find these strategies. So what happens during one of these typical meetings, the 2-hour meeting? There's always a social phase so that parents can connect with each other and exchange resources and so on. And each week they've got exercises to do, so we get some feedback on the exercise they've done over the last week, and then we watch the video clips as we've just done today. Then after that, it's the leader who demonstrates certain positive strategies. There's some role playing. The parents have to practice the different strategies that they've come up with themselves, amongst themselves. And then after that, we explore how this can be applied at home, and we plan the exercise for the week to come. So, for example, if I ask you, in the light of these strategies that we've come up with, to have positive reinforcement, for example, and to avoid giving too many orders and so on, what is the timetable in the week that would be best for you? The best moments in the week to apply these strategies, in other words. And parents work in smaller groups. When they do this type of exercise, we divide them up into small groups, and then we come back into the larger group to share all of this with their leader. If we look at the main trends, and it's not the night of the elections here, we've got lots more time on Saturdays and Sundays, and if you look at people's timetables, well, it's after 6 p.m. often when working parents come back home, when they're more available. But if we did this for parents whom we meet with in the groups, then we'd have more or less the same thing across all lines and across all timetables, because we've got parents that don't work, or we've got parents who work night shifts. So there's lots of different variations. And I wanted us to do this exercise because you can see here that with a group that's homogeneous in this group, and a group who shares common interests, and a group of professionals who are involved in interventions and care, it's quite a homogeneous group, and you can see that here already we've got quite diverse results. And that is really the key here when we talk about assessment, because when it comes to assessment, in order to get reliable results that we can analyse and that we can interpret, we need to have a great deal of homogeneity. Whereas in our clinical settings, often we're talking about heterogeneous situations. So I'll illustrate this difficulty for our assessments that we've done within this programme. You'll recall that our objective was to assess the effects of the COPA programme in the French-Canadian population. That's because we launched this programme when I was working at Adhd up in Lévis. And I worked with several CLSCs from Quebec City and from the South Shore in Quebec, where there is a community social pediatric centre. So that's where I established my first contacts with Dr. Julien and the CSP team. So we wanted to look at the impact on the children's behaviour. Do we have the effects that we find in the literature, and also what's happened with the parenting skills? And we chose a quantitative study methodology. So we want to quantify or measure something, and then we wanted to look at the results. So how can we quantify all of this? Well, the problem with quantification, I want to go through this more quickly, is that we need to have a great deal of information so that we can measure and understand what's happening. But at the same time, you know that in a clinical setting, we were discussing this during the break, sometimes we've got 15 minutes to assess a patient, and that's it. If we only have 15 minutes, then of course we can't ask them to take 3 hours to fill out questionnaires before the 15 minutes, nor after the 15 minutes. So it needs to be brief, and we've chosen 2 tools that are not perfect, but nevertheless, they allow us to cover a great deal of things, and they're scientifically very much validated in both of them, the CBCL and the verification of the different disorders. It takes about 20 minutes, and then there's the parental stress index that takes about 20 minutes as well. And we ask people to take the questionnaires before and after the group, in 6 months and then 12 months after the group. And if we look at the CBCL, you can see what this looks like. 100 questions, takes 20 minutes to fill it in, and it's grouped into internalised and externalised forms of behaviour. That gives you an idea of our results up here on the screen. We've got pre and post significant results, and this is maintained after 6 and 12 months after. And then with the parental stress index, it's the same thing, around 100 questions. And we're talking about rapid, brief questionnaires here. And we don't have a great deal of information with these questionnaires, but nevertheless, we've got some interesting results. We know that we have a reduction in many factors that can be related to parental stress, whether it's isolation or the depression index, and so on and so forth. So what were the issues that came up here? There's lots of different issues because we were targeting children under 5 years of age. And these are details, but they're details that make life very difficult for us. So in our cohort, we had parents who wanted to integrate their children and let them join, who were 6, and we thought we shouldn't exclude them. Let's go for it. So It was a generous choice, but it was a choice that made it very difficult for us because the CBCL stops at 5 and then starts again at 6. So we had two tools, and so it was quite difficult to analyse of this. So you can see that this is the sort of detail that can be a niggling detail. Other parents said we want to include our child who's under 5 years of age, but we want to use the same strategies for brothers and sisters because it doesn't work to use one strategy for a 4-year-old, but for an 8-year-old we've got the same problems. We're saying, no, you're not part of the research, so I can't use these strategies. So we did include their brothers and sisters, their siblings, and when you include siblings, then there is some bias introduced because you've got children that have not genetically linked and others who are genetically linked. In terms of analysis, that's another element that makes it more complicated to analyse these data. We also had parents where it was only the mother who was participating or just father. We could analyse them separately, mother and father, but there were also parents who alternated. So what do we do? One came to one session and then the father, for example, came to the other session. That's real life. So how can we assess this? And what should we do with these data in real life? And that was even more the case for people filling out the questionnaire. Sometimes the parents divide themselves up, and sometimes the father was responding for one child and the mother was responding for another child. That was okay, but sometimes both of them wanted to fill out the questionnaire and they didn't agree on the perception of the child. So that meant the questionnaire that was meant to take 20 minutes would take an hour. So you can see just how complicated it is to assess all of this in terms of the population and also in terms of the instruments or the tools used. And then, of course, there's the control group. For a study to be valid, there needs to be at least one control. And so it was difficult to come up with a control group. We had to make choices there, and we made these choices rather late in the day. And we didn't take into account those who would actually drop out. All of that will have an impact on the analysis side of things. There's just 1 minute left, and I could talk about this for hours as to what we did with all these different assessment scales, because we could set these up, for example, by telephone before the group got started, but then we lost a great deal. And it's when the parents are on site that they really fill out these questionnaires, but the practitioners didn't want to ask for people to fill out these questionnaires. So the research centre had to be there in 2 hours. It was a bit tight for the programme, so they didn't want us to interfere with the clinical programme, even though this is our clinical programme. So there were some arguments between the research side and the clinical side of things. So who is actually going to deal with all these different scales? That was a real difficulty. We did come up with solutions. They're not perfect, but we have to bear in mind that there's all of these different issues at stake when we kick off. It's important to bear all of that in mind because sometimes we deploy enormous efforts to collect data, and then when it comes to actually analysing these, it's very difficult to analyse them at all because it's too heterogeneous and it's not the same person who's done this and it's not at the same time, and so it becomes rather complicated to analyse the data. I'd just like to say that if there's something I want you to take away today, please remember this image so that when you want to carry out assessments, and when we're in this intervention context in the so-called clinical setting, but not always, it can be in a community setting, then we're dealing with interventions specifically. And we have to strike the right balance between clinical feasibility on the one hand, something that has to be feasible in the clinical setting, and also, on the other hand, scientific validity. Sometimes when we give too much weight to scientific validity, it's no longer feasible. That's sometimes what happens with pharmaceutical trials. There's so many restrictive criteria that it doesn't actually work in any clinical setting. But if, on the other hand, you place too much emphasis on the clinical side of things, it's not as valid. So we really need to strike this difficult balance. So that was on the quantitative side of things. Turning now to the qualitative assessment, this is a methodology that I've discovered and I don't yet master it, even if I've been working on this for over 8 years. But it's less demanding, it's less well known, and sometimes it's less rigorous, but not always. So I'd like to encourage you to look into this type of methodology where we have focus groups or group interviews. We've done this with a particular approach, as well as this satisfaction questionnaire. And this showed us the strengths and the weaknesses of the programme, the strengths of the implementation, and what would make it easy and what would make it difficult to implement this. And here I'm just citing a few examples up on the screen to show that, yes, the parents were satisfied. If I take account of the different subjects, over 90% of them were satisfied with all the different subjects explored. And when they talked about this, they were saying that, yes, so we started with a baseline, it was well structured, and we got good results. And if you look at the visible effects on the behaviour of the child, we can see that over 70% at the third meeting had already started to see visible effects. These are also interesting data. Sometimes it's a bit less demanding to actually collect these types of data. So what's at issue with this type of qualitative assessment? We couldn't have longitudinal data. It's difficult to have a control group because if somebody hasn't received something, it's hard to talk about pre and post, whereas if it's a questionnaire, it's easier to set up a control group. And in these focus groups, we did the focus groups with the leaders, but they're the ones who are leading the programme. So there's this subjectivity bias. When you have assessments, you try and concentrate more on the positive side of things. And once again, this also applies to the parents. I'll just skip over that slide. I'd just like to say that this is a project that was subsidised by the different research organisations at a national level. And I'm going to finish off with a second video clip just to show once again how this programme works. I need to just come back and click on it here. Please, sit down and stop fighting. Okay, thank you. That's enough. I already said that you have to stop jumping and fighting. If you don't stop, you can't watch your favourite TV show tonight. Okay, Dad, we're going to stay calm now. Could you please stop? It's the 5th time that I've seen this. It's going to finish badly. You won't be able to watch your favourite TV show tonight. We won't start again, we promise. Okay, it's the last time. I'll give you your last chance.
Merci votre.
Thank you for your attention.